Hello, welcome again to Miami Community Health. I'm Dr. Anthony Gonzalez, here educating you and educating our community about health topics. Today, we're talking about the heart. We're talking about the heart. We're talking about heart surgery. So I've brought a friend and a colleague, Dr. Joseph McGinn, here with us to talk about heart surgery. Welcome, Joe.
Well, thanks for having me, Tony. I really appreciate it.
All right. So before we get into heart surgery and surgery on the heart, let me tell you, surgery on the heart is not for the weak of heart. But before we get into that, let's learn a little bit about Dr. McGinn, who Dr. McGinn has been with us here at Baptist Health now for nearly 3 years. Let's learn a little bit about him. So, Joe, tell us a little bit about yourself.
Okay. Well, I was born and raised in Brooklyn. As a matter of fact, I always joke about the fact that if you took a radius of about 10 miles from where I was born, I did everything. I had all my kids, got married, did my medical school. Everything was in that 10-mile radius. So I'm really a New Yorker, and my Brooklyn accent will probably come out sometime during this interview. But coming down to Miami actually feels pretty comfortable because it's very similar to New York.
Just a little warmer, and there's no seasons here.
Yeah, the weather is definitely a little different, but I love the all year round weather, and I'm a boater, so for me this is a big deal.
So yeah, boating is big. Yeah, actually, it's similar. It's similar to me because I was born in Miami, raised in Miami, went to college, medical school, everything here in Miami, been in Miami. So we're very similar. I hope I don't end up in New York now.
No, it doesn't go that way. It only goes one direction.
It's only fly south. Flying south.
Only goes south.
All right, so let's talk about heart surgery. So tell our viewers and our listeners, what is heart surgery? Of course, you're operating on the heart, but what are common things that people are having heart surgery for?
Yeah, well, that's a great question. The most common operation that we do is coronary artery bypass grafting. Many people recognize it as a triple bypass or a double or a quadruple bypass. As a matter of fact, in the United States, there's 350,000 people get coronary bypass every year. So it's a very common operation. Next down the list is valve surgery. There's a lot of people have either leaky valves or valves that are stuck shut. And those valves can usually get changed out. That's the second most common operation. But between those two, that's the large part of what we do.
All right. And so, of course, historically, and we're going to get into this, historically, to open somebody's chest and get into the heart and do like a bypass operation, you have to actually break open their chest and break their breastbone, their sternum, and break it open. Is that right?
Yeah. We call it cracking the chest open. It's kind of a crude way of referring to that incision, but it's called a sternotomy or the zipper. Or, so many people have seen someone with it or have it themselves. It's just such a very common incision, and almost all heart surgery can be done through that incision. My whole quest is to figure out a way of doing it without cracking that bone open and having that healing time and so on.
And before we get into the surgical techniques, so when we do a bypass or triple bypass, explain to our viewers, we're trying to deal with blocked arteries, right? Because people, heart disease, very common in our country. People have blocked arteries. People can die from a major blocked artery. Explain to what we're trying to do, because we're going to get into some of these techniques, but I want them to understand what you're trying to accomplish on the other side.
Yeah, you're exactly right. These vessels that bring blood and oxygen to the muscle of the heart get blocked. It's the process of atherosclerosis. We're all familiar with it. When we eat too much fat, sit around all day, eat too many cheeseburgers, we clog up our arteries. The arteries that get clogged up most are the coronary arteries. These are the arteries that bring blood and oxygen to the muscle of the heart. Without that blood, you have a heart attack, and that's what can potentially take your life away. So what we do is we reroute the blood from the proximal side or the beginning side of the vessel to the distal side or the end of the vessel, so that the blood reroutes around the blockage and avoiding any heart attack, as you'd mentioned.
And usually, historically, and correct me, you guys used to take veins from the legs to reroute. Is that something that's still being used?
Yes, veins are used quite commonly. Almost every single patient gets internal mammary artery bypass. What is that? Well, inside the chest wall, there's an artery called the internal mammary artery. That artery, for whatever reason, is extremely durable. It lasts a really long time. So we use that on almost every single patient. We use veins to augment that. But there are several different materials we could use for the bypasses. The number one is the internal mammary artery. The number two used is the vein from the leg. And number three is a radial artery from the wrist of the arm. Those are the three main areas where we get bypass material for.
Okay. And then the other operation you talked about is valves. So
Mhm.
obviously we have valves in the heart, and
Yep.
you can have leaky valves and
Mhm.
malfunction valves,
Yes.
which can lead to problems. And you guys will repair the valves, change the valves. Talk a little bit about the valves.
Sure. So just to break it down, there are two main valves that we work on. The aortic valve is the most commonly worked on valve in the human body, and the mitral valve is the second most common. And most of the aortic valve surgery is done for either replacement. We can do replacement on the aortic valve in two different ways. One is through a traditional surgical approach. We do it always minimally invasive, but through a traditional surgical approach, or we can do a transcatheter approach. Many people have heard of the word TAVR, TAVR, transcatheter aortic valve replacement. So that's the more common scenario. Patients get a transcatheter that goes through the groin. The valve gets deployed inside the old valve, and the new valve does the function for the heart.
Wow. Okay. So now we understand, what we're trying to fix. We're either trying to detour around blockages in the arteries, or we're trying to change valves, replace valves, and so forth. So you already mentioned it. You talked about minimally invasive surgery. And, minimally invasive surgery is something I'm very common with, because in the abdomen, we have done minimally invasive surgery since the late 80s, laparoscopic surgery, and now robotic surgery. But let's talk about minimally invasive surgery in the heart, because you guys are not using, laparoscopic equipment for that, I don't think. But explain to us, what is a minimally invasive heart surgery?
Yes, that's interesting phenomenon. All the different specialties in medicine have moved to a minimally invasive platform. As you mentioned, general surgery has lock, stock, and barrel moved to laparoscopic or robotic surgery. GYN, orthopedic, you name it. Every specialty has a platform for minimally invasive. Cardiac surgery has been very slow. I'm a major proponent of minimally invasive platforms, but it's been very slow going. And I think part of the problem is that the heart is one of the few organs that actually moves to have its function. So that's one of the challenges. And also the arteries are very small. We're talking about 1 to 2 millimeter arteries. So there's a lot of challenges involved in creating a minimally invasive approach. But having said that, we need to move ahead because we need to catch up with all the other specialties. And that's one of the things that I'm a big proponent of.
So how do you guys do minimally invasive surgery? And I want you to explain to us also, I remember, back, in the 90s when I was, in training, we always stopped the heart for heart surgery, and you put somebody on a heart-lung machine.
Yeah.
And that was, the first time I saw that was pretty impressive, how you guys stopped the heart.
Yeah.
I'm like, I cannot believe we're stopping the heart. And then you start the heart again. It was like, I couldn't believe that. But now that's not always the case as well. So explain to us how you do minimally invasive surgery,
sure.
and talk a little bit about the stopping and not stopping the heart.
Yeah, that's a great. I every time I see that happen, I'm also impressed. It's amazing that we can stop the heart for a certain period of time and then restart it and everything's fine.
It's crazy.
Yeah, but I'm fascinated by what I do. Quite honestly, I love what I do, and I'm fascinated by it. But what we're doing now is we're not stopping the heart. We've actually got some engineering gizmos that can position the heart, stabilize the heart, so we can actually do a bypass surgery without the heart-lung machine and without stopping the heart. And it's really revolutionized the way this works. Just the heart-lung machine alone, you got to imply that there's some problem with it. It's not a good thing to have the heart-lung machine on, but it's not the worst thing in the world because there are certain operations we can't do without it. But for coronary bypass, for the most part, we don't stop the heart anymore, and we don't use the heart-lung machine.
Wow. Okay. So let's go to Baptist and what's happening at Baptist. So, Dr. McGinn, as I mentioned, is our chief of cardiac surgery at Baptist, been with us now for 3 years. So talk about what we're doing at Baptist today and what are some of the revolutionary things we're doing there.
Yeah. So as I had mentioned before, one of my big pushes is to create a minimally invasive platform for cardiac surgery, for all sorts of cardiac surgery. So we put together a team where there's 5 of us now, 5 surgeons. We all have expertise in different areas, and we're all in this mindset of innovation. We want to create solutions that are modern, that are cutting edge, that are not even done anywhere else. So we've got a team together that right now I could safely say we do more minimally invasive surgery than any place probably in the whole country.
Wow. Okay. And so what are some of the things that we are doing in regard to that? And what are some of the technologies that we're utilizing and or developing?
Yeah. So nationwide, it's about a 9% of surgeries are done off pump without the heart-lung machine. We do over 75% of our cases are done without the heart-lung machine. We have the highest number of patients getting minimally invasive coronary surgery. and virtually all of our valve surgeries are done minimally invasive. So we have put together a team that's super innovative. I mean, we probably could be compared to any organization in the country right now as far as how frequently and our success rate for minimally invasive.
So how does that extrapolate to the world? I mean, is the world doing this as well? Are there other countries that are even better than us? Because I know sometimes we fail and fall behind. In Europe, a lot of countries are doing more things we're doing in my world of general or bariatric surgery.
Yeah, there's different reasons for it, but yes, in Asia in particular, India, China, Japan are really advanced in their approaches to these kind of surgeries. Some of it's economic because the shorter length of stay, the quicker recovery time, and so on is a big factor for some of these countries. And there are other reasons for their advancement in this world. But I visited India, visited China, visited Japan to collaborate with the surgeons over there to advance the minimally invasive platform to get it more adopted in other places.
All right. And so why are, you said 9%, I think, of all coronary is done off pump without the heart-lung machine, and you guys are doing 75%. Why isn't there more adoption to minimally invasive heart surgery? Let's just say, let's focus on our country. Why not in our country? Even big cities, you know?
Yeah, that's a great question. I think for multiple reasons. Number one is the approach has been tested over time, so people are comfortable with it. Number two is the learning curve. It's not something you just go and you learn. And I'm sure you remember when you first started doing laparoscopic surgery, it's not as though the first case went perfect. I mean, there's a learning curve. I mean, there's a safety margin, of course, but there still is. It takes a little bit longer to do a minimally invasive case than it does to do an open case. So you have to be dedicated. And there's also other factors involved in no need to move towards a minimally invasive platform. But quite honestly, I think the public is pushing us in that direction. I think the patients are almost demanding it be done minimally invasive at this point.
Oh, no, there's no doubt. I can tell you in my world, I've had patients come to me and want a robotic procedure when it's really not indicated. I tell them, it's like you have a cockroach and I'm pulling out a shotgun to kill a cockroach. There's going to be more damage than good. Now, is there a technology limitation in that? I'll give you our analogy. In our analogy, there's some hospitals or health systems that cannot afford the technology of a $2 million robot and the money associated with it. Is there a lot of technology around minimally invasive heart surgery, minimally invasive heart surgery that maybe a health system or a hospital can't afford?
Yeah, there's no question there's an added expense to doing these things minimally invasive, but there's a pickup on the other side. Like, for instance, patients go home earlier. They get out of the hospital sooner. They get back to work almost immediately. My patients, I tell them, give yourself about a week after discharge, then go back to full activity. That means driving, swimming, working, lifting, whatever you want to do. Wow. So that's a big economic advantage for our society. But there is an added cost factor for doing the actual case.
All right. So actually, you're letting your patients go back to work and do activities faster than me, because I limit them to at least a month of no heavy lifting. So that's incredible. Now, I know even before you came there, as we were recruiting you, as a leader at Baptist Health that I knew about a technique that you had developed. And so I'd like to hear a little bit about it, about your McGinn technique, of course, named after you, Joseph McGinn. So tell us a little bit about the McGinn technique and what is that all about and how does that fit into all of this?
Yeah. So basically what I was able to do is replicate what we do through the sternal incision or the zipper, if you want to call it, only doing it through a small incision on the left chest. We're able to get between the ribs without damaging any muscles, without cutting or breaking any bones, and we can get access to the arteries of the heart by using two really fancy gizmos. One is a positioner, and what a positioner is basically a suction cup on the end of a long stick. It goes in, connects to the heart, and moves the heart around so I can get to all the different arteries on the heart. Then secondly, once we dial in, I like to call it, in that artery, then we can use a stabilizer to hold the artery still so that we can create the bypass anastomosis.
And so how do you physically get, I've seen heart surgery and you guys are wearing loops. The sutures are tiny, the needles are tiny. How do you guys get all the way in there? Are you using longer instruments, the equivalent of laparoscopic instruments?
So that's an amazing question, because one of the things is dexterity. You want to have that amazing dexterity. You need to do these little anastomoses with tiny sutures and 1 or 2 millimeter vessels. So the further you are away from the target, the more dexterity you lose. So the closer you are, the better. So the principle behind this is we make a small incision in the left chest, and then we pull the artery we want to bypass into that incision, it's close enough that we can now use our regular instruments to create the anastomosis. So that's if we were to do it on the end of long sticks like you do in laparoscopic, it would be almost impossible.
Wow. So, I'm old enough to have seen when the robot was brought, I think in 2003 to Baptist for heart surgery. And as you know, it really never took off. Why has it not? Why is there so much more popularity in this minimally invasive approach versus a robotic approach?
Yeah, no, there's no question. Robotic is an alternative way of doing a heart surgery. The problem is it's very expensive, not just expensive, it's very expensive. And secondly, not necessary. I like your analogy. You're using a tool that you don't necessarily need to use to get the job done. And we can do it much faster with the technique that I use.
All right. So we've learned that, minimally invasive heart surgery is obviously better. Patients go back to work faster, recover faster, get out of the hospital faster. So there's a value, what I call value, for the procedure. Now, is everybody a candidate for minimally invasive heart surgery? Who is, in general, who is and who is not a candidate?
So the short answer is everyone's a candidate. I look at everybody in my office or in the hospital that has consultation with the intention of figuring out a minimally invasive solution. And we can do it to almost any patient. I would say that in my practice, about 98 to 99% of patients are getting minimally invasive approaches. So yeah, but there are some patients who it's a little more challenging. Morbidly obese patients are very difficult because, as I mentioned before, you want to get that dexterity factor by having the artery close to you. If you have another 3 inches of body fat between you and the target, you lose some of that dexterity. So those are not beginner cases. The other kinds of cases, if we have someone with very diffuse disease that has maybe needs 6 or 7 bypasses or has, or we're not sure where the bypass is going to go, that happens maybe once or twice a year. So it's not very common, but those are the kind of patients we don't do.
How about patients who need repeat heart surgery?
Yeah.
Can you guys do those minimally invasively?
The short answer is yes, and we do. We do them short. We do them. Most of the cases that come back for a redo surgery are ones that did not have an internal mammary artery. So we can add the internal mammary artery when they come back for repeat surgery. So yes.
Wow. Incredible. So what does the future look like in all of this minimally invasive? What do you envision, for the future of minimally invasive cardiac surgery? Is there something that's missing, something that would help, that would make your life easier?
Sure. So we always talk about the great equalizer, and that would be a connector. In other words, what is a connector? A connector is how we connect the conduit or the bypass material to the artery in trouble. And the way we connect it right now is, believe it or not, by hand sewing it. If there was an automated connector, this would be something that would revolutionize this. Then I would imagine that every patient in the country would be getting this minimally invasive surgery. There are other challenges, engineering challenges, and anatomic challenges that we're trying to get through. But one of the things I've been also very involved in is teaching other surgeons. I've always had surgeons come from all over the world and our country to learn how to do minimally invasive surgery. Unfortunately, with COVID, that all been shut down. Yeah. So we're really just getting back started in teaching other surgeons. So you asked me what's the future? The future is that I get to teach more surgeons how to do this so that this thing is done in every state in the country.
Yeah, that's great. That's a great analogy because we try to do the same thing. There's only a certain number of patients you can operate on that I can operate on.
Exactly.
And so if you can expand your reach by teaching. Now, in today's cardiac surgery training, you guys have a fellowship where for our viewers, after they go through 5 years of general surgery, now you guys do a few extra years of heart surgery. Are they teaching minimally invasive surgery? Is there a subspecialty? Like what's happening in general surgery is that, I have a fellow who spends a year with me now to do advanced MIS, minimally invasive surgery, robotic surgery, and bariatric surgery. Is this being learned by the everyday heart surgeon who's coming out in training?
Yeah. So the answer is we're doing exactly what you guys are doing. So we're having another fellowship after the fellowship for cardiac surgery because just learning heart surgery takes more than 2 years.
Yeah.
So having that extra year to learn minimally invasive heart surgery is so valuable and necessary.
Wow. Are we planning to have one here at Baptist Health?
Yes. Eventually, we're going to have a program where we're going to train fellows, but also going to train surgeons who are already accomplished surgeons.
Oh, that's great. That's great to know. All right. So I know that there was a recent case in Carolina, and I want you to talk to us about this case and tell us how this case was so important and how this patient benefited.
Yeah. So it was an interesting patient, a lady who had a breast cancer, very treatable breast cancer, but was undergoing chemotherapy. During the chemotherapy, she developed some chest pain. They did a workup and found out that she had very tight blocked arteries. In addition to that, she had a blocked up aortic valve. So she had both problems.
Oh my God.
She had a blocked up arteries and blocked up aortic valve. So what we were able to do, and obviously, she had lost her hair and she was struggling with the chemotherapy, but a very curable cancer. So you can't really do a big incision on a patient like that. The wound won't heal. They won't tolerate. So because she was in our institution, we were able to offer her a minimally invasive coronary bypass solution. And then 2 days later, she had a TAVR, transcatheter aortic valve replacement, and then resumed her chemotherapy a week later.
Wow.
So this is a lady who, in any other hospital, they either would have done nothing, or they would have done a major operation, which would have been fraught with all kinds of complications and problems.
And it would have delayed her chemotherapy, because
Correct.
you can't start chemotherapy for at least a month or more, and then allowed her cancer to progress.
Exactly. So,
wow.
So this lady got a really amazing solution, and something that you can only do in a place that does a high volume of minimally invasive stuff like we do.
Wow, that's great. That's great. All right. So the future we talked about connectors. What about conduits? When you talk about heart surgery, you talk about you're trying to replicate connectors and have something that you can connect the artery or the vein to. What about the actual conduit? I know historically, and I did vascular surgery, 20 years ago, and it was all these plastic conduits, which were not great, and I don't know if they're great anymore. But are there any good conduits in the future?
So the direction I would take this answer is into arterial bypass graft material. So arterial bypass material lasts longer than anything else, than veins in particular. And we have tried plastic tubes for the bypass material, and they don't last long at all. We're lucky to get them 6 months.
Wow.
Whereas an internal mammary artery from inside the chest can last 20 plus years. So my goal right now is to do as many total arterial bypass as I can. So if someone gets a triple bypass, they might get a left internal mammary artery, a right internal mammary artery, and a radial artery.
Wow.
So if we do a total arterial bypass, we can almost guarantee that patient have a very much normal cardiac life, as long as they change some of the risk factors. Of course, we didn't get into that whole thing about risk factor modification, but if they modify their risk factors, such as eat the right foods, exercise, and so on, and they get a total arterial bypass, that could be a cure for them.
And can we harvest these arteries from cadavers and so forth? Is that possible? I imagine that's been thought of. It's just something that came to me now as you're talking.
Yes, there is an available cryo vein, which is a cadaver vein.
But not a cadaver artery.
Not a cadaver artery. And the cadaver veins don't last very long either. So.
Wow. So for our reference, how you said an internal mammary artery can last about 20 years. What does the average vein, the veins that they take from the legs, the saphenous veins, for our viewers, how long could they last?
Yeah, so it varies. And I don't want to scare people and tell them it, because I'm sure a certain number of our audience have vein grafts. They last as long as you take care of them.
Okay.
The key to all conduits and their longevity is how you take care of yourself. Do you take a statin? Are you exercising? Do you eat the right foods? Do you control your blood pressure? Is your diabetes under good control? These are all factors that affect the longevity of these grafts. So yes, internal mammary arteries last way longer than veins, but is there a specific number? I don't really have a number for that.
Okay. Well, you've made a great point where what patients should desire is never to see you. Right.
Exactly.
Right. I mean, if you take care of yourself, and we've heard this over and over here on this show, eating correctly, exercising, no smoking, taking the medications. If you have high blood pressure, high cholesterol, then you're not going to have that atherosclerosis. And if you don't have the atherosclerosis, you may never need Dr. McGinn. You may never need the McGinn technique, and you may never need all that, which is right. It's the best. It's the best preventative. Is the best therapy. Isn't it?
I would say hands down, that is one of the biggest challenges we have, is to get people to understand that they can change the future of their heart disease by taking the right medication, exercising, diet, and so on. But I will also say that there are people who have genetic issues, and they are cursed with having bad blocked arteries, and they could try as hard as they want, and sometimes it won't make any difference.
And I'm sorry, my brother-in-law, I think at 50 something, had a quadruple bypass there at Baptist. 10 years ago. I think it was 55, 10 years ago. He had it at 55 years old. I mean, it's like bad genes.
And we also have a lot of diabetic patients who, that can be partially inherited or it can be, acquired, but either way, they have bad atherosclerosis as well.
Wow. Well, I've learned a lot. I've at least learned, that we don't do as much on pump, which is great, because that was pretty scary for me. So I want to thank Dr. McGinn, and I want to thank our viewers at Miami Community Health for listening to us. Thank you for all the great work you do and what you've been able to accomplish in the last 3 years here and bringing that technology and really in the world of minimally invasive surgery. So now we have two things in common. We grew up and did everything in the same area, just, different cities, and we both love minimally invasive surgery. So that's been great. So Joe, thank you for coming. Thank you for educating our viewers, and thank you for taking care of our patients.
Oh, Tony, thank you for having me. I really appreciate it.
All right. Well, Dr. Anthony Gonzalez here from Miami Community Health. Once again, thanking you for viewing and watching. Once again, take care of yourself, take care of your family, and have a great day.